Thank you, Sator, for that introduction, and thank you everyone for attending. Are you gonna put up the slide?
Yeah.
So I'm mostly going to focus on stroke because May is Stroke Awareness Month. So, but particularly it does pertain to hypertension as it is a significant risk factor for stroke. So, did you share the slides? I can't see them.
Wait a minute. I think what I did was I pulled it up and didn't hit. I thought I clicked share, but hang on. Give me a second. Sorry about that. All right, 1 minute. I did something wrong again. Just 1 minute. I hit the wrong thing. I gotta pull my slide back up.
Okay. All right. So thank you, everybody. Again, I'm Tiffani Dennis. I am a primary care provider, internal medicine at Martha Jefferson Internal Medicine. And if we can go to the next slide. That's fine.
Okay.
Just want to go through briefly the objectives. Our goals today hopefully are to define the different types of stroke. And then I'd like to kind of review some statistics in the United States, and particularly as it pertains to Black Americans and our stroke risk and events. And then discuss specific risk factors for stroke. And this is where the hypertension will come into play. And then after that, review some means to prevent stroke events. Next slide, please. So I say a stroke is a brain attack because most of us think about heart attacks and we're pretty familiar with a heart attack. And a stroke is really a very similar event. It's the same thing that happens when you have a heart attack. Essentially what it comes down to is all the cells in our body at some point need oxygen to function. And if you don't have oxygen to the cells of the brain, those cells will die and it affects your function. So when a stroke occurs, that's what's happened at a cellular level. But what people notice or what the manifestations of a stroke are things that we all know about: paralysis or weakness, the inability to use your muscles, something called aphasia, which is a difficulty with speech. And some of that sometimes has to do with the muscles. So people will have slurred speech if the muscles of their face are weak. But you can also have difficulty where a person cannot form words properly, or the words that they're saying don't make sense. And that can also be the result of a stroke. Apraxia is another area of the brain that is affected. Will develop trouble with coordination. So you're not able to walk well, or you might have jerky movements, or you can still use your arm, but you can't do it to accomplish certain tasks. So that would be if a different area of the brain was affected. Confusion or kind of altered orientation is also a result of a stroke. And then patients can have paresthesia, which is numbness or loss of feeling. Next slide. So we won't spend much time on this. Hemorrhagic strokes are about 13% of all strokes, and they're what we would call a brain bleed. This may result from trauma. So if you have a blow to your head, a car accident or something to that nature, the blood vessels in the brain can be damaged, and then you can have bleeding into the tissue. You see on that picture there towards the left-hand side, that big area of red is blood that's gone out of the blood vessels into the tissue. And so that area where it's covered in blood, that part of the tissue is not getting oxygen from the blood, the arteries as they're supposed to. Another way that this can happen is from an aneurysm. So if you see on the picture to the right where that black arrow is, that area, that artery is kind of bigger, it's rounder and bulbous. That's an aneurysm. That's where the weakness in the muscle or the walls of the arteries cause it to stretch. And if it's stretched and weak, it can break easily. So aneurysms can break, they can rupture, and then the blood can leak out that way. And that's another cause of a hemorrhagic stroke. An AVM, or an arterial venous malformation, is another cause of hemorrhagic stroke. You can be born with these. It's a collection of arteries and veins that are kind of jumbled up. They're not formed properly. And so because they're not formed properly, they're fragile. It's easy for them to break open. So that could be another cause where someone, or another reason that someone might have a brain bleed or a hemorrhagic stroke. Next slide. What we're going to talk about mostly tonight, though, pertains to ischemic stroke, because this is the vast majority of strokes that people will encounter. And this is, again, no oxygen to the tissues, the cells, because the blood flow is blocked. So if you see that picture to the right, at the bottom, there's a normal artery. The carotid arteries are the arteries in the neck. So that's where it's showing what it would look like if you could see inside. There are a couple of different ways that you can block the blood flow in those arteries. And one is the next picture up, where you see the yellow on the sides of inside of the artery. So I think of it like your pipes in your house when they get stuff built up in them. And you know that the flow is slow when there's something built up in the pipes. And it's the same thing. A plaque is built up in the pipes. If you get a blood clot or something that breaks off from somewhere in your body and it gets into that area, it's already narrowed because of the plaque. The blood clot blocks off the blood flow totally, and areas past that are not getting blood supply. So that tissue that's past there does not get blood or oxygen, and that's where the stroke occurs. Even if you don't have damage or plaque in your artery, you can also have a blood clot that can block an artery if it's the right size. So that's another way that you can have an ischemic stroke. We often think about people having atrial fibrillation, which is a cardiac condition that is predisposed, or people are prone to have blood clots that form in their heart. And way down at the bottom of the picture, you can't see where it would be. Your heart is down there. If a blood clot forms in the heart and then it flies up into those arteries in the neck, then that clot can travel into the smallest artery at the end that can damage the tissue in the brain. So that's another way that you can have ischemic stroke, even without a plaque. Next. So the sad news is that this data from 2018 shows that someone in the United States dies from a stroke every 3 minutes and 33 seconds. That's pretty sobering if we think about over 400 people dying from a stroke every day. That's why this is important. That's why this month and the whole rest of the year, thinking about how we can prevent stroke is necessary. Next slide. For us specifically, it's important because we're 50% more likely as Black Americans to have a stroke compared to our white counterparts. And Black women in particular, twice as likely to have a stroke compared to white women in this country. So that's pretty upsetting to me, especially if this is something that we can work on. Next one. So this is the details of why we're doing this. If you hit the little advance, the good news is go ahead and hit next. The good news is that can be prevented. Strokes can be prevented. So I want to spend a lot of time talking about how can we prevent this. Next slide. So first, we have to know the risk factors if we're going to have any impact on preventing a stroke, and ischemic stroke particularly. Next slide. Obesity, which is technically defined as a BMI over 30, something that you can work with Satur on specifically. Next. Hypertension or high blood pressure is also a risk factor for ischemic stroke. Next. High cholesterol or hyperlipidemia. Next. And smoking, cigarette smoking. Actually, I didn't add here, and I should just mention I did before, the atrial fibrillation, because remember that clot that you can develop in your heart, even if you don't have these other risk factors, that can develop into a blood clot in your heart that can travel to the brain. And that's why it's really important for people who have atrial fibrillation to discuss with their physician if they should be on a blood thinner or anticoagulation to prevent a stroke. Next slide. So obesity, I won't spend way too much time on this. Suffice to say, if you look at that second line, the row there, 80% of Black women versus 64.8% of white women over the age of 20 would technically categorize as overweight or obese. I don't like this data all the time. We know it is a risk factor. Obesity is a risk factor for stroke, but unfortunately, how we categorize people as obese and the other risk factors that go along with it may not be great. The BMI doesn't take into account your bone density. It doesn't take into account your muscle mass. So it's not a perfect measure, but it is something we see correlating with stroke risk. So I will mention it, but I think we have to take it with a grain of salt. Next. Hypertension, and this is a major risk factor for stroke. And if you look, Black women and Black men are more likely to have hypertension kind of across the board. If you're over age 18, we have a significantly higher risk of high blood pressure. But this is a major area that we can impact our stroke risk. First is having your blood pressure checked, and next is actually treating it. Next slide. The good news here is that high cholesterol, hyperlipidemia is a risk factor. But if you look at the left column there, that's Black Americans versus white Americans over the age of 20. We actually have less high cholesterol. So that's one area where we're doing a little bit better. Next slide. Excuse me. Cigarette smoking is something that I'm sorry that I still have to talk to people about, but it is definitely a risk factor. And if you just focus on the one circle there to the left, smoking has a direct impact on the blood vessels, which is what we're talking about here, really. It damages the blood vessels, can thicken the blood. So if the blood vessels are damaged, if you have plaque and your blood is thick, then just imagine that's more difficult for the blood to travel and more likely that you're going to have a clot. So it just makes sense that you'd be more likely to have a stroke, that or a heart attack. So this is a specific reason why smoking is a risk factor for stroke. Next slide. So how do we prevent stroke? Well, smoking cessation, that's a huge one. That is one that you actually, to some degree, have in your control, though it's not easy. But none of us need to smoke. Controlling your blood pressure with medication, with regular the physician visits is important. And medication, I'll mention cholesterol medication is a significant risk reduction, whether you've had a stroke or to prevent a stroke. If you've had a stroke, the single most important thing to prevent a future stroke is taking medication for your cholesterol. And your risk for stroke is decreased whether your cholesterol is high. Those statin type medications have an effect on the blood vessels and the plaque in your blood vessels. They do something different to the inflammation and the activity at the plaque level. And so they reduce your risk for stroke in a way that it is not solely because of the lowering of your cholesterol. So that's something important to talk to your doctor about. And then weight control or weight reduction are important as well. Next slide. I just want to focus on that top left corner there. Again, exercise, I talk to all my patients about exercise, and it's not really just for weight reduction, which most people think of, if I'm exercising, I should lose weight. But I just want to mention that there's benefits specifically on the blood vessels. And if we're talking about blood vessels, that's what we're talking about with regard to stroke, that just exercising regularly has benefit. You increase something called nitric oxide, which helps the cells that line the arteries. It actually improves the kind of chemicals or myokines that work against inflammation. So all the things that can cause damage and buildup of plaque in the artery can be improved with exercise. So this is just purely exercise. This is not adding medication. This is nothing else. So I can't stress enough to people how important it is to get on a regular exercise regimen, even if you don't get to your ideal body weight. There is benefit just in exercising. Next slide. Oh, and I want to mention this concept of time is brain. So if we go from the left side of this slide to the right side, the left side is 0 hours or the immediate incident of a stroke. So you have a stroke and you see that area where it's very black in the brain. That is the area where the tissue is already dead. The blood flow has been stopped. Those cells are dying. But the little purple area around there is an area at risk. That means those cells are stressed. Those cells are under duress. They may be dying, but they're not dead yet. So we have time to improve that area if we can get blood flow to that area. Did you go to 4 hours from the initial stroke? You see that black area has spread. So there are more cells that have died the longer the time after the actual incident. And that purple area is smaller because there's more dead tissue. So the area that was at risk is now dying. And then when you get to days, that area of dead tissue is spread significantly. So if you think about how quickly should you get to the hospital, well, we found it's within 3 hours, we can help improve the blood flow, and that area of purple can go back to normal tissue. So that means that the extent of your stroke, how severe your symptoms are, is significantly affected by how quickly you get help, how quickly you get to the hospital. Next slide. So that's where this acronym comes from that you might have heard, FAST. The FAS has to do with identifying symptoms of a stroke. So facial drooping is one of the tests to see if someone's facial muscles are affected by a stroke. You ask the person to smile to see if their face is lopsided or it seems uneven. A has to do with arm weakness. It doesn't have to just be the arms, by the way. Moving the legs or having weakness in the leg can also be a sign of a stroke. But ask an individual, can they move their arms and legs properly to see if they look like they're having a symptom of weakness from a stroke. And then speech difficulty is, can the person speak clearly? Do they have slurred speech? So are the muscles in their face affected? Or are they having trouble with saying words, getting words out? So ask them to repeat something you said. And if they can't get the words, can't repeat the words clearly, even if it's not speech or they can't say anything, then that could be a sign of a stroke as well. The T stands for time to get help. If any one of these things is positive, remember, time is brain. You need to get that person to the hospital, or yourself, you need to call EMS. That's an emergency, because the longer you wait, the worse the damage from the stroke. Next slide, please. Oh, I want to mention this phenomenon called a transient ischemic attack. It's not actually a completed stroke, but it is something people call a mini stroke. Basically, this is something where a patient may present with, say, weakness, or maybe my right arm is numb for a couple hours. But to be defined as a transient ischemic attack or a mini stroke, those symptoms completely resolve within 24 hours. But oftentimes I'll have a patient that calls and said, well, yesterday, my arm was numb all day, but it's fine now. I feel fine. And those people I want to see right away. Because the problem with a transient ischemic attack means your risk for a completed stroke is increased. What happens with a transient ischemic attack could be that you had a small blood clot that went into the blood vessels of the brain, but it actually broke down. Your body was able to break it down pretty quickly. So the tissue did not die. But the problem with that is that you could have another stroke. And unfortunately, within 90 days after a mini stroke, somewhere between 2 and 17% of people will have a completed stroke. And within a year, 1 in 5 people will have a completed stroke if they suffered a TIA. So this is not something to ignore. Even if you have symptoms and you feel like, well, they're gone, I don't need to see anybody, you absolutely should see somebody. Next slide. So just wrap it up, that this is May, this is Stroke Awareness Month, and I hope that what we talked about has increased your awareness of stroke, that you might focus on knowing what your risk, your loved one's risk for stroke, that prevention and looking at the preventive factors that you can modify is important. Knowing the signs of stroke is also important, and getting help if you do have symptoms of stroke as quickly as possible so that you can prevent any damage. Next slide, I think, is just opening up to questions. So I want plenty of time for questions. If anyone knows who that is, go back to it. Does anyone know who that is? That is Rebecca Lee Crumpler. She is the first African-American female physician. She got her medical degree in 1864. Pretty amazing. So Tor, if you're talking, I can't hear you.
I'm sorry, I was saying, I didn't want to go back to the beginning of the slideshow because I ended the slideshow, I think. I don't know, let me try. So I put it here at the end, so. I'm sorry. Okay.
Okay, questions?
I still keep hitting that. Great, okay. Unmute your phones, which I'll help you with in a second if you need to do that. Anyone have questions? This is your time. You can unmute your phones and fire away. Lots of people are still muted, but.
Dr. Dennis, I have a question. This is
Yes.
Steve. How do you feel about, I heard about the recent aspirin study, like regarding daily use of aspirin. Is that something that you still recommend a little bit? It
Yeah,
seems
so
like,
yeah, no, thank you for that question. I think that is something I've already gotten questions about from my patients. It's unfortunate how that information is conveyed in the lay press. And so I'll point to a couple things. One, we do know that taking baby aspirin increases your risk for bleeding, particularly gastrointestinal bleeding. So blood in the stool, stomach ulcer bleeding. And we know that, and we know people over the age of 60 are higher risk for that. So the kind of recent studies have looked at that and tried to evaluate who really should be taking baby aspirin or low dose aspirin. And what they determined is people over that age really don't benefit from reduction in their risk of cardiovascular disease, strokes, or heart attacks if they take baby aspirin just as a preventative measure. But that does not apply to people who've had a stroke or have had a heart attack or who have peripheral artery disease. So if you have known blockages in the arteries in your legs, if you have known coronary artery disease, you've had a stent, or if you had a heart attack, if you've had a TIA, or if you've had a stroke, that does not apply to you. So those are what we call secondary prevention, meaning you had an event and we want to prevent another one. So I always encourage people, talk to your provider first before you decide to stop using aspirin. And it may be that it's inappropriate. There are certain patients who were taking it, say they just had high cholesterol or they just had hypertension and they're taking a baby aspirin. In that case, it may not be appropriate, but you should speak to your provider about that.
okay, thank you.
Anyone else? Don't be shy. You want to speak about the impact of salt in our diet, in our culture?
So I want to ask a question about the baby aspirin.
Okay.
Because I had a blood clot and I had a knee surgery. So I have been taking that baby aspirin for some years now. For some years. So should I continue to take that? Because, you know, I take a cholesterol pill and I also take a blood pressure pill.
So if you are taking the aspirin on your physician's direction, then I would say yes. But generally speaking, I don't recommend a baby aspirin to prevent blood clots. So just generally speaking, if you had a blood clot in your leg, like a DVT or something like that,
Yes.
that's not necessarily recommended, a baby aspirin for that. So I'd really encourage you to talk to your doctor, make sure they know you're taking baby aspirin every day, make sure they're aware of that, and then you can have a discussion. But generally speaking, I do not recommend it for that specifically.
Okay. Thank you.
Good afternoon, Dr. Dennis. This is Shawnee. I have a question regarding high blood pressure, like eating salty foods. And I know right now with the new blood pressure, I think they increased it now. So I think I was 120 over 70 or 120 over, I think it was 80 used to be okay, and now it's not. It's on a higher side. But my question was like, is it a myth that if you happen to eat salty foods that day and you have somewhat of a normal blood pressure, if you happen to have salty foods, drinking water, will that kind of dilute the salt in your body? I've heard people say that increasing your water intake may dilute it.
Right. No, so if you just had a salty diet like the day of or the day before you go get your blood pressure checked, it's not going to have the same impact as a cumulative effect of lots of sodium in your diet. So drinking a lot of water is not really going to have the effect that you want. It's not. I've heard that too. Patients said they tried to drink a lot of water to dilute it out. That really, they're really not going to do it. So generally speaking, probably most of us have too much sodium in our diet. Some people tend to be more salt responsive than others. For whatever reason, we find that African Americans are somewhat more responsive to sodium in the diet, meaning if you have a lower sodium diet, your blood pressure will probably be better, which means your cardiovascular risk will be lower. And so when I say lower sodium, that means about 1,500 milligrams of sodium per total per day for the whole day. And you know, if you were actually measuring it out in table salt, a half a teaspoon is about 1,200 milligrams of sodium. So it's a little bit more than half a teaspoon for a whole day. And depending on what you eat, if you eat out at a restaurant, if you're eating something in a can, you know, God forbid it's ramen noodles or something like that, you could blow your whole sodium budget for the day with just one meal. So for us, it can be very important. And generally speaking, 2,400 milligrams, 2,400 milligrams, or like a teaspoon of sodium per day is what's recommended for everyone. But if you have high blood pressure, if you're African American, then that number goes down to 1,500 milligrams of sodium recommended per day.
Okay, thank you.
Welcome.
Anyone else? Are we going to give everyone, what is it, 17 minutes or 20 minutes? Well, no, it's almost not quite 30 minutes, but nobody has any questions. Everybody's exercising and drinking all their water and eating low salt diets and doing great.
So it's not just low salt diets too. I should mention the DASH diet is something that a lot of patients about. You know, it's old data studies to show that if you're on a low sodium diet, if you exercise and you have a diet that's high in things like calcium, magnesium, and specifically potassium, then those things together can lower your medication as much as lower your blood pressure as much as one single medication. So for everybody across the board, if you're already on a low sodium diet and you want to improve your blood pressure, just, you know, instead of drinking a lot of water to try and dilute out the salt, trying to get like lots of fruits and vegetables, things with high potassium, like melon, potatoes, tomatoes, apricots, fish. Those things have a lot of potassium. I know bananas everyone talks about, but they actually aren't the highest in potassium. But high potassium foods, lots of fruits and vegetables, low sodium diet, and exercise also can be critical in lowering your blood pressure. When you say exercise, it doesn't have to be super intense exercise. You know, you can just go out for a brisk walk. And when I say a brisk walk, I don't mean, you know, a leisurely stroll with my dog who stops at everything every, you know, 5 feet so she can sniff it, but, you know, kind of walking where you feel like you're rushing a little bit. That's the kind of intensity of exercise we like people to work up to. And if you can do that for 150 minutes a week or 30 minutes, 5 days a week, that's it. You know, that there's real benefit to that type of exercise. You don't have to run, but running, swimming, you know, those types of things are a little bit more intense exercise. You can do those for about 75 hours or 75 minutes a week and get the same benefit. Pushing a lawnmower counts too. So if you have to push a lawnmower to walk in your yard, cut the grass, that walking counts. You can add that to your exercise too.
What about vacuuming?
You know, that's funny. I don't know. Vacuuming, we might need to look at whether or not vacuuming. You can get some pretty intense vacuuming. It can be hard on your body. It can be hard on your back.
Yeah, I pulled a handout from, I think it was from the American Heart Association that listed vacuuming. I forget what the time frame was, but there was some benefit of vacuuming. So.
Yeah. Yeah, we don't talk about it. Yeah.
I just want to make sure I heard correctly about the foods to lower your potassium, your sodium. And it was like, you said potassium foods like melons and potatoes.
Yeah. So potatoes, tomatoes, dried apricots, melon, those all I think have even more potassium than bananas, but bananas are on the list of high potassium foods, some fish. So if you kind of incorporate those into your diet, you know, what we want is high potassium, low sodium. That's really good for your blood pressure.
Thank you. Okay.
Anyone else?
Yes, potatoes. Isn't that also bad for your diabetes? So can you do a sweet potato instead? Would that do the same thing?
Yeah, you can. And so I do mention potatoes, but I think everyone, you have to work within the confines of your diet and what's best for you. Other conditions, right? You don't want to eat a ton of fruit if you have diabetes, right? And sweet potatoes are somewhat better. But even if you have diabetes, a small or half of a potato with moderation is not going to be bad. But yeah, absolutely. I mean, somebody with heartburn or acid reflux, I'm not going to tell them to eat a lot of tomatoes either, because that's pretty acidic. So that's going to be bad for them. So you still have to kind of go through the list and figure out what's best for you.
Okay, thank you.
You're welcome.
Anybody else have any questions? Well, if no one else has questions, we will be able to end early today. So I'll challenge everyone to go out and take a brisk walk this evening. It's nice.
20 minutes.
We gave you 20 minutes to get out and walk. Drink a glass of water when you get back.
Yeah, it's hot out there.
Thank you, Dr. Dennis, for your
Thank
time.
you so
Thank
much,
you so
Dr.
much.
Dennis.
Yeah.
Very valuable
Thank you.
information. Yeah.
Yes, very much so.
Thank you.
Thank you all for attending. I appreciate it.
Yeah.
And y'all have a great evening.
Yeah, it was very informative. Thank you so much.
Yeah,
it was.
Thank you.
All right, everybody.
Bye-bye.
Bye-bye.
Bye.
Amy, you doing okay? You're muted. I can't hear you. Unmute. Can you unmute your phone?
Can you hear me now?
Yeah.
I called you to apologize for missing my meeting last week.
Let's see, which day was you? Yeah, you had an appointment one day, but then I thought you may have got confused because you came by and got your blood pressure and weight checked, I think, that day. So then I thought, well, maybe she counted that as her appointment.
No, I
Anyway.
can't. I don't know, 'cause I can't be made an appointment for the 21st of April.
Mm-hmm. Yeah.
So
You were, did you change your mind on the plant-based class, the cooking class?
No, I didn't. I forgot. And then when I saw your email, it was too late. It was after 11 o'clock, but I wanted to do the 5 o'clock one, and I didn't see anything about 5 o'clock until today.
Oh, yeah,
So next-
she's doing a 5 o'clock. I had you down for the evening one.
Okay, well, to that, when I read your first email, it talked about 11 o'clock.
Mhm.
I don't know if I had missed one before that or not, but
Okay,
anyway, I saw the one where she's gonna have both times. So I will be there next Monday and my daughter at the 5 o'clock one.
okay. Because the 5 o'clock one actually had more people, but other people have signed up now for daytime, so it's working out. But she's only done one class so far, and that was yesterday at 11. And,
Okay.
well, 2 classes. She had the morning class at 11 and the evening class at 5. Yeah, so every Monday this month, until there's no classes on the 30th. So it's every Monday for the next 3 Mondays. She's gonna
Okay.
have a morning class and an evening class. It's the same class. So if you, if you sign on, it'll be this, you only have to come to one, not sign on because it's in person, but you only have to attend one class.
Okay, well, I'll be there next Monday afternoon.
Yeah, everybody enjoyed it on Monday. They liked the foods that she cooked and the examples and things, so we'll see.
So,
And-
Satua, when is the evening yoga class gonna start?
The evening yoga class does not start this week. It starts next Thursday because the instructor wasn't available this week. Only the morning class starts this week. And I've been having a hard time getting enough people for the morning class, but we're getting a few more. But the
So
morning
next
class is tomorrow. The morning class is tomorrow at 10, from 10 to 11. It's supposed to be Wednesdays, 10 to 11 a.m. and Thursday evening, 6 to 7. So right now the evening class has 1, 2, 3, 4, 5, 6, it has 6 people signed up for the evening. So
Did I for that? Not for that, the evening class of the yoga? I don't know.
Yes, you did, because you said you needed to come in the evening for I think your granddaughter or something.
Yeah. Okay, I have to write that down too.
I'll send everybody a reminder that the evening class doesn't start until next Thursday. I have said it in the email, but I know I've been sending so many emails because it had so many different things going on between the cooking classes and the the cooking classes and then the yoga classes. So it's been a lot trying to keep it straight.
So is the yoga class, is that at 6 o'clock?
Yes, that is at 6 o'clock. That one is later because we thought, for some people who work, it's easier for them to come in the evening like that. So we did that one 6 to 7.
Okay, so where is that at?
They're all of the yoga classes are held here in the building, but over on the Parks and Rec side. So enter over on the Parks and Rec side. And when you come in, you can take the elevator. It's up on the 3rd floor. There's a classroom up there.
Okay.
All right, y'all have a blessed evening.
You do the same. Take care.
Okay, thank you.
All right, y'all be good.